So we're back, and now we're continuing on with our podcast between the two shoulder expert societies, the American Society of Shoulder and Elbow Therapists from the United States, and then the European Society for Shoulder and Elbow Rehabilitation, obviously from Europe. So what we are going to do today, we're going to jump right in. We're going to actually talk about tennis now. So now we're getting into factors that affect injury as well as return to play decisions with tennis specifically, since this is a common sport for all of our countries. And so what we're going to do is we're going to introduce our speakers today. So today we have Natalie Myers from the United States and representing ASSET. Natalie is an assistant professor in the Department of Health and Human Performance at Texas State University. Dr. Myers received her Bachelor of Science in Athletic Training from Elon University, as well as a Master of Science in Athletic Training from California University of Pennsylvania. Dr. Myers received her Doctor of Philosophy in Rehabilitation Sciences from the University of Kentucky in 2017. She's had the opportunity to work closely with the Women's Tennis Association and the United States Tennis Association Sports Science Committees, contributing to tennis medicine in the professional and non-professional environments. Her research currently focuses on the clinical management of tennis players with the goal of improving performance while diminishing injury risk. More specifically, Dr. Myers is interested in load management strategies amongst tennis players and the clinical evaluation of the tennis serve. Natalie also serves as the associate editor for the Journal of Medicine and Science in Tennis and has had the opportunity to speak nationally and internationally at both coaching and sports medicine conferences. Our other expert who is representing EUSSER, this is Milena Mirkovic, and she is a sports physical therapist with over 10 years of experience in treating tennis-related injuries, all the way from recreational up to professional tennis players. She completed her physiotherapy degree with honors and her clinical masters, both in Melbourne, Australia. Apart from tennis-related injuries, she also has a special interest in treating shoulder injuries. Her honors thesis was about clinical tests used to predict SLAP lesions, in particular the active compression test and its basis. She is the chair of EUSSER's Education Committee and has lectured at various conferences as well as published work on the topic of shoulder rehabilitation. Millie divides her time between a full-time physiotherapy role with the Lawn Tennis Association, looking after elite British tennis players, and private physiotherapy consulting in London. So Natalie and Millie, welcome.
Thanks for having us.
Thank you very much, Aaron.
You're quite welcome. So let's get right into it, since everybody's dying to hear what we got to talk about today. So Natalie, let's start with you. So as a practicing clinician and a clinical researcher in tennis, which aspects of return to play following shoulder injury are we knowledgeable in, and what are we really deficient in?
Yeah, it's a great question, Aaron. So to answer the question, I tend to gravitate back to the consensus statement on return to sport that Arden published in 2016. Yeah, we know that return to sport is multifactorial and decisions really shouldn't be made in isolation. The consensus statement that they wrote about actually summarizes these different models that should be considered when returning an athlete back to sport, such as the Biopsychosocial Model, this principle known as Goldilocks principle for progressive loading. And then lastly, they talk about the strategic assessment of risk and risk tolerance and how that helps estimate the risk associated with return to sport. Interesting, the paper had a plethora of return to sport stats specific to lower limb pathologies like ACL, hamstring growing, and even Achilles injuries. Yet the return to sport rates and the factors associated with return to sport with regards to shoulder, specifically in tennis, are really quite minimal. We do know from some of Ellen Shanley and Kevin Wilkes' work assessing range of motion deficits in baseball and softball athletes, and found shoulder motion to actually be correlated with increased injury risk. They found that a loss of internal rotation between about 20 and 25 degrees with a corresponding loss of total range of motion greater than 5 degrees when compared bilaterally is actually a red flag in these particular populations. Additionally, there's been some new work done on the external rotation deficit And that's really just the difference between the dominant ER and the non-dominant ER. And we found that if it's less than 5 degrees, this may also be associated with shoulder dysfunction. However, again, these studies are very specific to baseball players and really haven't crossed that border into the tennis population as of yet. Also, workload monitoring is a hot topic right now with all the great work being done by Tim Gabbett and his colleagues out of Australia and Europe. His work actually suggests that we must pick both an external and internal workload parameter that are important to the sport and then systematically progress that athlete back into activity using what's known as this acute chronic workload ratio. This goes back to the Goldilocks principle that Arden discusses in the consensus statement on progressive loading. The acute chronic workload ratio is really just a way to monitor training load of the current week. That's that acute load against the previous 4 weeks, which is really that chronic load. The ratio is helpful in planning load progressions to return to sport. But again, the ratio has not been investigated specifically in tennis. I am currently working on a longitudinal study that will examine acute and chronic training loads using hitting volume, rate of perceived exertion, and their relationship to injury and performance in tennis players. But right now, it's not specifically out to this particular population.
Well, that's fantastic information, Nat. And so we see something here about motion, we see something about workload. So Millie, other than motion and workload, what is it that clinicians really should consider during this return to sport process following shoulder injury?
I think knowing the player's baseline physical and clinical profile pre-injury would be great to know, so that we know at least where the player should be returning to, not just from a shoulder injury point of view, but also the rest of their body, if not to an even better level than where they were pre-injury. We simply don't have enough information in research on the physical demands of the tennis game to be able to draw conclusions on what level that individual player needs to get back to, because it varies so much from player to player also. Therefore, individual player fitness, musculoskeletal profile, average training loads, like Natalie mentioned, and information about their scheduling and typical weeks can give us a better picture on how to build a better return to sport plan. I also think an area underlooked in the tennis population is the effect of equipment change on upper limb injuries. For example, a change in 5 grams of racket weight, whether it's heavier or lighter by up to 5 grams, can result in shoulder overload. Similarly, very stiff strings can result in greater demand on shoulder muscles because of the higher vibrations going through the upper limb. Any changes to equipment should be carefully planned and consequently monitored to ensure the shoulder doesn't get overloaded. But equally, as we do the rehabilitation process and even beforehand, when we do take the subjective examination, it's really important to hone in in the player's history as to whether they have made some kind of change 6 to 8 weeks prior to the shoulder problem taking place, because it may be also linked to a change in the equipment.
Okay, so now this is really a complex multifactorial type of issue, right? So we have clinical features, we have equipment features as well. So Millie, let's expand a little bit. So are there any clinical benchmarks that you feel must be achieved before you implement a return to sport program following shoulder injuries for tennis players?
There certainly are. I'm fortunate enough to be working in an environment where we do have players' baseline fitness and musculoskeletal screening data, so we can look back and see sort of where they were and those parameters. But if we look at the shoulder specifically and return to, let's say in this case, serving, aside from the usual restoration of full and pain-free range of motion into different planes of scapulohumeral movement, we have found some markers from literature applicable to this population, and they are, for example, the total passive range of motion to be no less than 5 to 10 degrees different to the non-affected side. I say 5 to 10 because in baseball it's 5 degrees, but in tennis we've seen differences up to 10 degrees to be present in healthy tennis population. So we accept even up to 10 degrees difference. The ER to IR isometric strength ratio at 90 degrees of abduction and 90 degrees of external ratio, of external rotation, sorry. We know from literature, ideally it should be greater than 0.66 compared to, obviously, sorry, it should be 0.66 on the dominant side, but clinically we'd like to bring that higher. We don't want to be on the cusp of risk. We want to sort of think about 0.75 ratio or higher. During rehab, ideally for the player to have no scapular dyskinesis, especially scapular reposition tests helped improve strength scores and or decrease pain during initial assessment. Another test I find useful is the Acromion to table length test, and for that to be no more than 10% different to the other side, usually reflective of pec length and or the level of thoracic kyphosis if they're an older player or recreational player. And I would say more recently, the work from Karen Ginn and colleagues has prompted us to look more closely at players' ability to perform active shoulder rotation exercises throughout the available passive range of motion with good control and under load. Therefore, we would like to see active range of motion as close to passive range of motion of glenohumeral joint rotation as possible. So this is just something new clinically, which we've discovered through reading a bit of literature and also correlating it with some of our injured and non-injured players who could be better with their shoulder function.
Wonderful. That's a nice comprehensive list of clinical benchmarks. So Natalie, do you have anything that you actually could add to that list?
Yeah, I certainly do. I think it's also important to assess, some lower extremity and trunk function. There is limited literature to suggest lower extremity dysfunction increases the risk of shoulder injury, especially in a tennis population. But I don't think that means that the lower half should actually be neglected. We should still be looking at that lower half. We do know that from Angela Tate's work, that adolescent swimmers with shoulder pain have decreased core endurance, specifically in a side bridge position compared to those without shoulder pain. We also know single leg balance deficits are apparent in overhead athletes in general with shoulder pain. So incorporating balance-based clinical tests that challenge not only the lower extremity but the trunk may actually be beneficial. It really could be something as simple as the Y balance test or even some type of variation of a plank. Now, aside from objective measures, I also think it's important to incorporate some subjective measures before implementing a return to sport program. It can be something really simplistic and just asking a simple question is, how confident do you feel in starting the return to sport progression? Understanding the patient's psychological views is an important part of the return to sport process as a whole.
And very good. And we touched on that quite a bit in our last podcast in regards to swimming, on how those pieces are very important. So it's nice to see some crossover between multiple sports. So now that we've talked about the risk factors, we've talked about the clinical benchmarks. So Natalie, why don't you lead us into some functional maneuvers or some physical performance measures that you would implement into your return to sport progression following shoulder injury?
Sure. Functional tests really are limited for the upper extremity. However, there are a few that I would recommend based on my own clinical experience and what is known in the literature. The Y balance upper quarter test is similar to the lower extremity balance test, but instead you're in a push-up position, stabilizing with one hand and then touching a tape measure in kind of different planes of motions or different directions. Boehm and colleagues actually established normative values in both male and females, and those are really between 80 and 90 centimeters depending on the sex. And this was in overhead recreational athletes, but the validity of the test, it hasn't been studied yet, so we're unaware of it at this point. Boehm also suggests that the use of the medicine ball throwing for distance test can be very beneficial. The player seated with the back against the wall and actually propels the ball forward as far as they can. Again, this test has been shown to correlate with isokinetic shoulder and elbow strength, so there is some validity to it, but we don't know if it's able to discriminate between an injured or a healthy population. Again, there's normative values for both males and females ranging between 200 and 300 centimeters. I would also recommend a power hopping maneuver, such as the multi-directional hop test for distance. We have some normative data for this in professional women's athletes, but again, we're unaware if the test is able to discriminate between injured tennis players and healthy tennis players. While not a functional test per se, I do like to incorporate some type of stroke assessment at this stage. So there are clinical-based observational tools that you can use to evaluate stroke efficiency for all strokes on court. Dr. Neeru Jahanthi and Mirkovic have actually developed an assessment tool for all three major strokes, so forehand, backhand, and serve. And then my colleagues and I have really spent time concentrating on developing one specifically for the tennis serve. And specific to that, to the tennis serve, we found that individuals with proper serve mechanics, as assessed by this clinical observational tool, demonstrated not only greater trunk flexibility, but rotational power through a medicine ball throw, and actually higher single leg counter movement jumps as well.
Oh, well, wonderful. So these functional or physical performance measure type of maneuvers really do have some value to us. So Millie, what would you add to that? What are you getting to do, or what do you know of that you believe clinicians should be using?
I think functional tests are great in principle, and I do agree with Natalie that we still need a lot of research in elite tennis population before concluding on the applicability of upper limb functional tests to help us with decision on return to tennis following an injury. For starters, they are not functional to tennis movements or the serving motion, and our players usually never train in these positions, such as some of the tests. So we don't even expect our healthy players to perform well on some of these tests. So until we know more about correlation of these tests with our healthy tennis population as well as the injured populations, and until trends are established, I'm right now a little bit reserved to some of the functional tests, and I'm happy to rely on clinical tests which target individual muscle groups along the chain of serving and ensure those muscles and joints are functioning well on their own, as well as the player's overall fitness markers before moving directly to serving and serve analysis using tools such as the observational tool, which Natalie mentioned.
Well, wonderful. Well, thank you very much for this information. So this really now leads us into probably a very important question, or the question we're trying to get to with this topic. So Millie, why don't we start with you? So, once this clinical, once your clinical or your functional benchmarks have been achieved, so now how do you progress the athlete back into the game in regards to getting them ready for participation? And, are there differences in progression between ground strokes and overhead strokes? So can you help us out with that?
Certainly. Well, in my experience, most shoulder overuse injuries in tennis are associated with only the tennis serve, and so overhead shoulder motion is the problem. And generally, they are okay hitting ground strokes. Of course, there are a couple of exceptions, but I'm talking about the majority of problems that I see. Therefore, return to ground strokes can happen as soon as they can demonstrate that they have pain-free and full arc of motion, normal and pain-free strength values below shoulder level, good humeral head control during basic resistance maneuvers below shoulder level. They can paint, shadow swing their ground strokes pain-free, and this can happen within a few days from initial injury or from when they present, so that or that initial shutdown period, and that way we minimize deconditioning on court, as well as any secondary niggles that can relate to prolonged time off of tennis. As well as that, they don't have to build up ground strokes so slowly if they only had a couple of days or a few days off court. And so returning to overhead strokes, on the other hand, requires a lot more careful planning, because it usually has been quite a few weeks since their last serve, And so we don't want to undo all the work by overloading the shoulder too soon. And we have some research from the US Open that an average number of serves per set per player is about 42 to 43 shots, depending on whether you're male or female. But we need to build them up to be able to serve up to 130 serves per session, assuming 3 sets, per day, because they often play from one day to another when it comes to competition with no days off, unless it's a Grand Slam. And they need to be able to do that 5 days straight to match the demands of an average, as I said, 3-set matches and going deep into a tournament. Therefore, building up from 0 serves per week to about 650 serves per week requires some careful planning of serve counting using guidance from work by authors such as Tim Gabbett and colleagues, while also thinking about each individual player in front of us. Another variable to consider when progressing serving is the intensity of serving. While returning to full intensity ground strokes is typically quick and time on court is the variable factor, on returning to serve, we must consider both the intensity of serving as well as the number of serves hit, so two different variables. So the demands on the shoulder during a serve hit at 50% pace are different to a full intensity serve. So the published work by Natalie and her colleagues on graded return to serve volume and intensity following an injury is a good guide to clinicians. However, I think each player is slightly different, and some players, in my experience, simply don't know how to slow down their serve to, let's say, 50-60% without breaking down in their kinetic chain. So we must use our clinical reasoning and get feedback from player and coach about the best way to proceed with building up serving intensity in this case. So should we be looking to start at 50% serving pace and build up intensity slowly while increasing the number of serves more rapidly, or the other way around if the player simply can't slow down their serve without changing the way they serve?
Wonderful. And so this idea of volume-based training and progressions. So Natalie, this is something I know you've been working on. So can you provide some guidance on really how to increase volume and intensity once return to sport has really rolled into the picture?
Sure. And I think it's important to have a plan. Once a player is released, they should still try to be monitored over the next 3 to 6 months if possible. In my own research, I currently use what's some technology by Sony called the Sony Smart Tennis Sensor to actually measure hitting volume. And for more on the intensity side of things, I use a self-report rate of perceived exertion scale. The Sony Smart Tennis Sensor actually attaches to the end of the racket handle. It weighs only about 0.2 ounces, so players don't seem to have any issues while using this technology. And we've had some research that will hopefully be published here in the next coming months that shows that these sensors have a less than a 10% error rate when compared to visual observation when counting strokes. So let me try to provide you with a practical example. So let's say you have a period of 4 weeks to train a player for an upcoming week-long tournament. In this particular example, let's define load as rate of perceived exertion times the session duration, which gives us what's known as a session RPE, or a session rate of perceived exertion. The first step is to actually determine the ceiling load that you want that person to endure. So you can use previously published literature to determine these loads if it's available, or even make an individualized plan like Millie said, because everyone is different based on the athlete's previous level of competition if that information is available to you. In terms of intensity, the goal is to work at max intensity once that player is competing at the actual tournament and tournament competition. So as you start your 4-week training, perhaps working at lower intensities during the beginning of the week for a longer period of time, and then increasing the intensity incrementally throughout the week while decreasing time on court may allow for progression and systematic training. And then kind of the last piece that both Millie and I have talked about is incorporating some of Dr. Gabbitt's work and using this acute to chronic workload ratio to really help gauge if players are preparing appropriately for activity. And again, the workload monitoring, the actual metrics can vary. I was just giving you one example using session RPE, but the same method could be used for monitoring hitting volume as well.
Well, wonderful. Thank you both, Natalie and Millie, for your expertise, for your contributions. The information has actually been fantastic. We're starting to see, as we mentioned earlier, we see this overlap now between what we heard information-wise from our swimming podcast and now our tennis podcast, where this is very much a complex issue. Making these decisions about return to sport, return to activity involves many different pieces, from the psychological components and subjective information, the clinical benchmarks, the risk factors, and then, of course, the physical performance measures. And now we got even more information about workload. So thank you both very much for that.